Hello and Yali Madat, everyone. Welcome to our Understanding Your Individual Menopause Experience webinar, a part of the Your Health is Your Wealth series. My name is Sarah Munji, and I'm a registered pharmacist practicing in Toronto, Ontario. I serve as a member of the Health Promotion National Programming Team on the Aga Khan Health Board for Canada, and I will be your moderator for today's webinar. The goal of this webinar is to provide valuable insights on menopause, what it is, how to recognize its signs and symptoms, and its impact on a woman's quality of life. We will also hear from a lived experience, offering a personal perspective on this important topic. Before we start, we would like to thank all the volunteers who have helped make this webinar possible. I'd like to start with the land acknowledgement, where we acknowledge the Indigenous peoples of all the lands that we are situated on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of these lands, the ancestral and unceded territory of all the Inuit, Métis, and First Nations people across Canada that call this nation home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Before we get started, we would like to inform the audience that any information that is provided in this webinar should not be considered specific medical advice and is not intended as a substitute for medical professional help, guidance, diagnosis, or treatment. We remind our audience to seek the advice of your physician or other qualified healthcare providers with any questions you have regarding your medical care. I now have the pleasure of introducing you to our panelists for today's session. Dr. Shafeena Premji is a mother, daughter, wife, artist, entrepreneur, and a passionate, dedicated women's health advocate and a menopause specialist in Calgary, Alberta. She is a family physician with a fellowship designation with the Canadian College of Family Physicians and in women's health. She holds a Menopause Society certification since 2015. She is also the founder and medical director of 3 medical clinics, Mahogany Medical Clinic, The Village Medical, and her most recent venture, Milestone, Menopause Center of Southern Alberta, which launched on March 8th, 2024. Dr. Premji serves on the board of directors of the Canadian Menopause Society and the medical advisory board of the Menopause Foundation of Canada. She has also made multiple media appearances advocating and enlightening menopausal women across the country. We next have Ruksana Samji, who is our lived experience for today's session. Ruksana enjoys reading, watching crime documentaries, and spending time with her 2 children. Her journey with perimenopause began almost 3 years ago. We would like to thank you both for taking the time to be here with us today. Over to you, Dr. Premji.
Thank you, Sarah, for the very warm welcome, and Yali Madats to everyone who is joining on the webinar today. It is a true privilege and honor for me to share my personal experience supporting women in various stages of their menopause journey, and also to providing you with evidence-based information about what women experience through their menopause transition, and to be able to give you some insights that will be of value to you as you speak with your own healthcare provider. So I just wanted to acknowledge that I do receive honoraria from various pharmaceutical companies, although there is no conflict that I can perceive from today's presentation. In terms of my personal background, I just wanted to give you a little bit of an understanding of my personal journey with learning about menopause. As mentioned, I am a family physician based in Calgary, Alberta, and graduated from Queen's University in 2013 with my residency in family medicine, as well as a fellowship in women's health. I received my Menopause Society certification from the Menopause Society in 2015, and over the last 10 years have worked with my husband to build 3 clinics, of which my most recent one is the Milestone Menopause Center of Southern Alberta, where I support women of all ages throughout their midlife transition. I'm also fortunate to be a board member of the Canadian Menopause Society since 2020, as well as a medical advisory board of the Menopause Foundation of Canada. So what I'd like to do over the next 40 minutes is talk to you about the following objectives. Let's understand what menopause actually is. Why is it important that we talk about menopause? Let's understand the history of menopause because that will help us understand why it is something that is still not well understood and why there's such a stigma behind aging for women. And then we're going to talk about what menopause means for us today. I'm going to help you understand the symptoms of menopause, what the impact of your symptoms are in terms of your personal quality of life, as well as the impact it has on the workplace, and then what I would do with a patient in providing a midlife women's health assessment. So let's get started. What is menopause? Now, I know this looks like a complicated slide, but it really does highlight for you as a woman to understand what happens as you transition through your reproductive journey from your first period to your last period. This is called the STROC criteria, which is primarily used in research, but we use this to help us understand in a more objective way how to quantify or qualify your perimenopause and menopause journey. So on the what you can see at the top is the terminology. And so the first thing I want to do is highlight that there's three important phases. The first stage is the reproductive phase. The second phase is the menopausal transition. And then finally, there's postmenopause. And we can understand that the first period is when we begin the first stage of reproduction. And we can also understand when we have our last period. Now, that's easy for women who are still getting periods. However, if you are a woman who's had a hysterectomy or you've had your ovaries removed as well as your uterus, or if you have an IUD in place, or if you've had an endometrial ablation, it can be more difficult because you're not getting regular periods. Now, what helps us define these three different stages is primarily that menstrual cycle. So what you can see is if we look specifically at the reproductive stage, this is the stage where women are in the peak years of their life to actually conceive and carry a pregnancy. So during this time, our periods are quite predictable. Periods are from anywhere from 21 to 35 days in length in terms of frequency. And generally speaking, we can predict when our period is going to come. We then enter into the menopausal transition, which we call perimenopause. And this is a term that's still quite vague for a lot of women and don't really understand what it means. But really what it means is that there's a change in your cycle length. And along with those changes, you may start to experience some symptoms. Now, perimenopause can be broken up into the early perimenopause transition and then the late perimenopause transition. So for women who are in early perimenopause, this can begin as early as in your late 30s or early 40s. And what we're seeing here in terms of your periods is that your cycle length starts to become more varied in that you may go even more than 7 days between consecutive cycles. So it might be less than 21 days or more than 35 days, and it's not as predictable as it used to be. And during this time, you may only have period cycle changes, but you may also have many other symptoms, which we will address later. When a woman enters into that late perimenopause, which is around 1 to 3 years from that final period, this is when periods become a lot more irregular. So if your period is going from 60 days to 364 days apart, this is when you're now in that late perimenopause transition, at which time women are experiencing a lot more of these vasomotor symptoms or hot flushes and night sweats that we will talk about in a moment. And then you have your final period. And once you have your final period, it's really when you look back 1 year later that you can say that that was my final period, because it's really made as a retrospective diagnosis once you've gone 12 months without any bleeding. And then you are in postmenopause or in menopause for the remainder of your life. And this is where hormone levels drop significantly. There's no further bleeding. And if you do have any bleeding beyond that 12 months, it may be abnormal and it does require investigation from a healthcare provider. So as I mentioned, we've talked about what menopause is, and why menopause occurs is because as women, we have the highest number of follicles in our ovaries actually when our mothers are carrying us as fetuses, around 20 weeks gestation. When we are born, we have anywhere from 300 to 600 follicles in our ovaries. When we then hit into puberty, that goes down to about half. And by the time we hit menopause, which the average age globally is anywhere from 51 to 52, we only have 1,000 eggs made left in our ovaries. So really menopause is because of a loss of ovarian follicular function. Now, the age that this can happen is anywhere from 45 to 55 for the average woman. But as I mentioned, the average age is around 50, 51, 52. The perimenopause, as I mentioned, is that transition from being reproductive to non-reproductive, where we've had changes in our menstrual cycle lengths, as well as many symptoms, and this can last anywhere from 3 to 7 to even 10 years. And then finally, postmenopause. This is the time that you are in menopause from that last final period until the rest, and then for the rest of your life. And this is where we have a significant drop in estrogen levels throughout our body. So what's happening during these various stages with respect to our estrogen levels? So as you can see, when we look at the top here, again, we've broken it down into 3 different stages. On the left, during that reproductive stage, when we're in our 20s and 30s generally, and we're getting regular cyclical bleeding, we can see regular predictable cycle changes in terms of estrogen levels. However, once we enter into that perimenopause transition, what you can see is that there's a lot of fluctuations in those estrogen levels. We call it hormone chaos. And from one day to the next, you may have a very high level of estrogen or a very low level of estrogen, and it's really not quite predictable. And this is why for the average woman who is above 45, who's beginning to experience cycle changes, we really don't order any hormone level testing because as you can see here, there's a lot of hormonal fluctuations. The only time hormone level testing in terms of an estradiol level or a follicular stimulating hormone level is ordered is when we are trying to determine if a woman has gone into menopause early, which is under 40, or prematurely under 45. So this is when a woman's gone 3 to 4 or 5 months without a period under 45, and we want to determine whether this is early menopause. But for the average woman who's having cycle changes, there really is no role in doing hormone level testing. And then finally, as you can see, estrogen levels deplete as we are in that post-menopause stage. Why are we talking about menopause? Why is this important? This is important because if you look back even only 100, 120 years ago, life expectancy in the 1900s was around 50 to 51, which is at the same time menopause occurred. So women were not even experiencing menopause because that was when they were actually passing away. But over the last 100 years, as you can see, the age of menopause has pretty much stayed consistent. However, now women are living into their mid-80s. So menopause is no longer an end-of-life event, it's a midlife event, which means we're spending 30 to 40 years of our life in menopause. And as healthcare providers, it's our responsibility to ensure healthy aging for every woman, because this is a long time to be in menopause and a time where women's quality of life is very important, as well as their overall health. And I want to invite you to think about aging as a privilege. As women, it can sometimes be hard to consider aging and feeling that we've passed the prime of our lives when we are no longer able to produce a baby or have children. But I really want to highlight to you that it's a privilege for us to age because menopause is a universal experience. Not every woman chooses to have a pregnancy or is able to carry a pregnancy, but menopause is something that if we live long enough, each one of us are going to experience. So I want to invite you to see this time as an opportunity for you to become a health advocate for yourself, to become a CEO of your health, to be empowered towards healthy aging, and to be confident in having a healthy menopause. And that's the purpose of what this today's webinar, as well as the next webinar, is about. So in order to understand the history of menopause, we need to go back a little bit into time. And I just want to go back into the 1990s. And why I go back to only that time is because hormone therapy, menopause, all of this was really quite not well understood. And if you may actually believe it, women were not even included in clinical trials until the 1990s. So really all of the information we had on medicine was based on men's health research. In around 1942, Premarin, which is one of the first forms of estrogen that was ever commercially available, was being used by women as a form of anti-aging for bone and health protection and health prevention, as well as to manage symptoms. But we really didn't have a good understanding of how estrogen was really affecting women in terms of their chronic health disease prevention. So in the early 1990s, the largest study of women was initiated, which was a randomized control trial, and it was called the Women's Health Initiative. And what they did is they wanted to understand whether estrogen for women who had had a hysterectomy or estrogen and progestin combined for women who still had an intact uterus were using these hormones not only to treat symptoms, but actually to understand was there actually a decrease in chronic disease events when women were on estrogen and progesterone. So in particular, we were looking at heart health in terms of reduction in strokes and heart attacks, in reduction in blood clot risk, and also for cancer prevention. So as you can see here, on the left, these are women who still had a uterus, no hysterectomy, and on the right, these were women who had a hysterectomy. So they were randomized. Randomized means that they were randomly chosen to be in one of two arms. So if the woman was a woman that still had a uterus, she was prescribed oral estrogen and oral progesterone, or she was on placebo. And if a woman had a hysterectomy, she was on estrogen only or placebo. Now, the average age of these women was around 64. They were actually already 10 years past their period, their final period, the majority of them, but the age range was between 50 and 79. Now, let's see what happened in the study. Well, unfortunately, about 5 to 6 years into the study, on July 7, 2002, there was information from the study that was leaked to the media. And this information stated that hormone therapy is dangerous because now women in the study were developing cancer, they were having heart attacks, they were having stroke, and they were having a higher risk of blood clots. So this became quite an alarm for healthcare providers as well as women who were on hormone therapy. And for those health practitioners who were practicing at that time, actually told me that it was the one day in their career they had received the highest number of callers from women after hearing this on the news. Unfortunately, what we did not realize at that time was that there was an overgeneralization of the information, and what was actually publicized in the media was actually relative risk. So what they said with that was that there was a 24% relative risk increase in breast cancer, which when you hear can sound quite alarming. But what I want to highlight in this slide is on the left, these are the women who are on estrogen and progesterone with a uterus. And on the right, the women who are on estrogen alone after having had a hysterectomy. And what you can see here is that the absolute numbers were actually quite small. There were only 4 additional strokes per 10,000 women in the 50 to 59 year age range, only 5 additional breast cancers out of 10,000 women, only 5 additional heart attacks, and 11 additional blood clots. Now, even these numbers are quite low in terms of numbers out of 10,000 women. And if you can look here, we also stratified this data based on age. So it was the women in their 50s, 60s, or 70s. And what you can see in this slide is it was actually quite low numbers for those women in the 50 to 59 year bracket, but increased for the women in the 60 and 70-year-old bracket. So what this really highlights is that hormone therapy actually has a window of opportunity. And that window of opportunity is for women under the age of 60, because the risk of these events are quite small overall. And you also want to keep in mind that these women were asymptomatic. The average age was actually 64. They initially generalized all of this data in one big lump sum. And finally, these women were women who already had previous heart disease risk. Some of them were smokers, some of them had high blood pressure, some of them were overweight. And now we have many other hormone therapies that have been approved by Health Canada to mitigate some of these patients who have higher risk. And so what happened after 2002? Well, as you can see, there was a significant decline in hormone therapy prescriptions by 80%. Unfortunately, menopause was no longer something that was discussed in the medical school curriculums because we just felt that hormone therapy was unsafe. And so really, there was really no option for us in terms of managing patients' menopausal symptoms. So healthcare providers who've been in practice for the last 20 years have had essentially no medical education from both residency and medical school. This then led to an increase in unapproved menopausal therapies, which means that women who were still trying to access hormone therapy were no longer able to access it from their healthcare provider, but now there was an increase in compounded hormones by other alternative practitioners. And the problem with compounded hormones is that they're unregulated and we don't have any large clinical studies or data to tell us that they're safe or efficacious. People were also prescribing higher levels of testosterone, which can be very dangerous and have side effects which can be irreversible. And on top of it, patients were spending excessive amounts of money, not only accessing their compounded hormones, but also having testing that was really not based on any evidence, such as the Dutch testing or salivary gland testing, which is not recommended by any menopause society in the world. So what does that leave us now? Well, the Menopause Foundation of Canada did a large landmark report published in 2022 to look at the stigma and landscape of menopause in Canada. And what we understand today is that 1 in 2 women, so 50% of women, feel completely unprepared for perimenopause and menopause, which is why this topic is so important to discuss. So what do we do now? Well, as a board member of the Canadian Menopause Society, and as a Menopause Society certified practitioner, we want to invite women to understand that menopause in 2025 has been reclaimed. We can now own our menopause experience and feel confident in advocating for ourselves because we understand that the Women's Health Initiative was unfortunately a dramatic effect on the ability for women to access appropriate care. But we understand now that that data was initially overgeneralized and that we have a better understanding and grasp of which patients can actually safely use hormone therapy for symptom relief and to improve quality of life. We have rebanded and redefined your menopause journey. It's always important as a patient to know where to access your medical information because in 2025, there is a lot of information online and there's a lot of misinformation. So we want to be very mindful of where we're getting our information from. So what I want to highlight here is some credible resources where you can access healthcare knowledge about menopause that I can vouch is evidence-based. So the Canadian Menopause Society, which website is canadianmenopaussociety.org, the Society of Obstetricians and Gynecologists of Canada, the website is menopauseNU.ca. Menopause Quick 6, MQ6.ca, is also an evidence-based information platform for both healthcare providers as well as patients. The Menopause Foundation of Canada is an advocacy group, not for profit, to help break the stigma of menopause for women in Canada. They also have a Menopause Works Here campaign that supports employees and employers in providing menopause inclusive workplaces. And finally, if you love listening to podcasts in your car, the one that I would highly recommend is a Canadian journalist, Melissa Grello, who has a podcast called Aging Powerfully with Melissa Grello, which has evidence-based information where she interviews some of the top experts in menopause in Canada on all different topics within your healthy aging topics. So now that we have an understanding of what menopause is, the history of menopause, and now as women, we can finally understand that we can speak up about our symptoms, let's dive into what those symptoms actually are. So I want you to consider that we actually have estrogen receptors throughout our entire body from head to toe. So this is a multi-system change and what I call a neuroendocrine change. And why I say neuroendocrine, neuro meaning brain and endocrine meaning hormones. So there is a very tight balance between what's going on in our brains and what's going on in our ovaries that leads us to experience many of these menopausal symptoms. So if we start up in our brain, the central nervous system, the hallmark of menopause is vasomotor symptoms, and that is those hot flushes and night sweats that you will hear from our lived experience Marie's later on, where women will experience flushing from either their chest up or from their head down, and this can be quite bothersome, and we will explore this further. If these hot flushes occur at night, we call them night sweats, and many patients can actually have a lot of sleep disruption because of it. When women are not sleeping well, when they wake up, they are then feeling more groggy, there's more brain fog, cognitive dysfunction, and there's a lot more depression and anxiety. So this then can lead into that woman's day where she may be having to care for her children, her aging parents, or even in her professional workplace. Women also report changes in their skin, hair, and nails. There may be a thinning of the hair. There may be a worsening hairline. Women will feel dryness in their skin. There may be more wrinkling, a drop in elasticity and hydration, which can have a significant impact on a woman's self-confidence. In terms of weight and cardiometabolic changes, a lot of women report weight gain during the perimenopause transition, and I hear from many women that they're eating the same food, they're exercising the same, but their symptoms are still quite bothersome, and they can gain anywhere from 10 to 20 to 30 pounds in a short period of time. Now, what's happening is that estrogen is actually a lubricant to our blood vessels. It's an antioxidant and it's an anti-inflammatory. So as our estrogen levels are dropping, we lose that anti-inflammatory and antioxidant components, and now we're beginning to develop inflammation in our bodies. That inflammation leads to an increase in blood sugars. That increase in blood sugars increases our risk of insulin resistance, which then increases risk for diabetes. And that's also then causing an increase in abdominal body fat. So we're gaining weight in that midsection, and we turn more into that android body shape, which can be very distressing for many women. There is also the musculoskeletal syndrome of menopause, which is now newly understood, where women will start to experience joint pains, arthritis, a stiff or a frozen shoulder, and then there's also a significant drop in muscle mass. And these have significant implications for women in terms of their future aging, in terms of their future function, in terms of their future risk of fall, and being able to continue to be independent as they age. And finally, there's the genitourinary syndrome of menopause. We have estrogen receptors in our vagina, vulva, bladder, and urethra. And these symptoms can sort of present very insidiously, and you may not recognize them, but it's important for you to know that vaginal dryness, itching, burning are symptoms of menopause. Changes in your urinary function, frequency, irritability, urgency, as well as bladder infections can also be a part of that menopause symptom experience. And finally, for women who do have partners, this can have a significant impact on your sexual function, both in terms of pain as well as interest. So vasomotor symptoms, as I mentioned, affect the large majority of women. Up to 80% of women experience this. And in terms of ethnic differences, what we understand is that African American women experience symptoms for the longest period of time and for the most severe symptoms as well. Hispanic women fall second in line. And in terms of South Asian and Asian women, they also do experience hot flushes, but what they actually also experience more so is that it presents more so in terms of joint pains and aches. Are vasomotor symptoms something that you just need to get through for 1 to 2 years, or is this much longer? Well, when we look at the study of the women across the nation, we actually understand that these hot flushes can last on average for 7.4 years, but there are some women that actually begin to experience these symptoms for almost 10 years. It peaks just prior to that final menstrual period and in those first 2 years after your final period. And it's not just that time. In fact, 40% of women are still having hot flushes in their 60s, my apologies, and 10 to 15% of women are still experiencing hot flushes even into their 70s. So it's important for women to know that these are not just one and done deals. This can have a significant impact on your quality of life when they're lasting for this period of time. So what is it in terms of personal quality of life as well as in the workplace? What do we need to understand? Well, actually, hot flushes and night sweats are not just one symptom that you need to treat, but it actually has impacts on your overall health. We now understand that for women who have the most severe symptoms, that they actually have an increase in heart disease. So we believe that vasomotor symptoms are actually a biomarker of heart disease. In fact, these women also have a higher risk of drops in their bone density, higher fracture risk, and sleep issues, which can be very, very bothersome in terms of difficulty falling asleep, staying asleep, as well as early morning awakenings. What about its impact on mental health? Well, vasomotor symptoms have a bidirectional influence on your mood as well as your sleep. We understand that women who do not treat their menopausal symptoms and their vasomotor symptoms well will have a higher risk of developing anxiety and depression. And in fact, women who experience hot flushes sometimes correlate them to having a heart attack or even having a panic attack. So we shouldn't take this lightly, and it's important that as healthcare providers, we really understand the impact that these symptoms have on your life. As you can see here, as I mentioned, having more hot flushes actually increases your level of anxiety. And again, the sleep perspective is important to also keep in mind. What about in the workplace? We actually have a very good understanding of how menopause impacts the workplace, thanks to the work of the Menopause Foundation of Canada. There are over 10 million women currently in Canada above the age of 40, of which 2 million are working women between the ages of 45 and 55. If we as healthcare providers do not adequately treat your symptoms, or if your symptoms are not recognized by yourself and you're not receiving the care that you need, it can have a significant impact on your ability to function in the workplace. There's higher work impairment, higher work absenteeism, and there's also a stigma around bringing up your symptoms in the workplace because you may feel judged or you may feel that you may not have the opportunity to move into higher leadership positions within your workplace because you would otherwise be appeared to be weak from your menopausal symptoms. And this is important for you to understand. In fact, 1 in 10 women will actually leave her workplace and leave the workforce because of unmanaged symptoms of menopause. So we want to really ensure women are adequately treated so that they can continue to function in their workplace. What about the actual economic impact? If you look at the number of women who are not in the workplace because of their symptoms, we actually now understand that there's a $3.5 billion of lost annual economic burden to the economy for women who are not in the workplace. And as you can see here in this Harvard Business Review, this quote says, menopause often intersects with a critical career stage of life between 45 and 55, which is also a time where women are most likely to move up into top leadership positions. If you want to continue to move the needle on the number of women in leadership roles and maintain their valuable contribution to a company's bottom line, we need to be more open about what menopause is and how it affects both individuals as well as organizations. So now that we understand what the impact of menopausal symptoms are, the next step is what can you do as an individual woman and how can we as a healthcare team and healthcare provider actually offer you a midlife women's health assessment. So what is a midlife women's health assessment? Well, currently in Canada, we don't have any formalized way of providing this to patients. We do have periodic health exams, which are recommended after the age of 50, but really we don't have a comprehensive way of addressing the unique healthcare needs for women in that 35 to 45-year age range before they actually become menopausal. And so I really want to highlight to you what I believe is an important part of this midlife women's health assessment so that you can make an informed decision with your healthcare provider about your symptoms and then consider appropriate treatment options. So the first thing is recognizing the symptoms. And then the second part is doing a risk assessment, looking at your breast cancer risk, your heart disease risk, and your osteoporosis risk. We always talk about lifestyle interventions, which promote healthy lifestyle. And then finally, creating an individualized plan for you, which takes into account your symptoms, your individual risk profile, as well as your preferences. So let's dive in. So I'm going to talk about a couple of patients to give you some perspective. So this is Shy Rose. She's 51 years old. She works as an accountant. She's married and has 2 children. She went into menopause 15 months ago. She is having the following symptoms. She's having hot flushes and night sweats. She's not sleeping well. She's having difficulties with her memory. She cannot remember words and having a difficult time functioning in the workplace because of her poor sleep. She's experiencing joint pains. She really wants to exercise but has no energy. She's feeling very fatigued. And in addition, she hasn't brought this up to her doctor, but she's also experiencing dryness in the vaginal area and has no sexual desire. Let's meet another patient. This is Alia. Alia is 46 years old and she works as a pharmacist. She is still perimenopausal. So she's still having periods. They are monthly, but they are varying in terms of length for up to 10 days differences between cycles. And she's having heavy bleeding. She is divorced. She's a mother of 3 children. She's in a new common law relationship. She does not smoke and may have 1 alcohol at most per week, but generally doesn't drink much. She's quite stressed in that she's having to take care of her 3 children and also work as a pharmacist. Interestingly, her mother had a blood clot after her 2nd pregnancy and worries about the safety of hormone therapy. So the first thing is, if you have any kind of medical history, if you're going to go to your doctor, the first thing is you must track your symptoms. And so here's a template that you can consider. There are many different forms of menstrual trackers or symptom trackers available online. This one in particular does take into account your individual periods. So this is a month-to-month tracker. And what you would do every day is document if you are bleeding and if you are experiencing any of the following symptoms. And why this is important to know is because maybe your symptoms are cyclical, and if they are cyclical, then it may be able to help you determine if your symptoms are more so in line with your periods, or if they are occurring more randomly. So once we've tracked our symptoms for at least 3 months, the next thing you want to do is take that menstrual tracker that you've downloaded off the internet or the one that I provided as a template to your healthcare provider, because now you can actually have an informed conversation about your periods, whether you're still having them or not, as well as what symptoms you're experiencing. So once you come to your doctor, this is what we as healthcare providers do. We offer and administer a questionnaire to really have a good understanding of what your symptoms are. We then do a risk assessment, and finally, we individualize your treatment plan. So let's go through this one by one. So what is the MQ6 screen? MQ6 really stands for a series of 6 simple questions which has been validated and for which we as healthcare providers can have a really good understanding of what your menopausal symptoms are. And this can be available as a free download from the mq6.ca website that you can actually print out if you wish and take to your healthcare provider. So the first thing is, let's talk about each of these individual questions. So the first question is, do you have any changes in your periods? So again, we want to understand how often you're getting a period, how many days you're bleeding for, and how heavy this is. So are you using 1 pad, 2 pads? Are you using a pad and a tampon? How often you're changing it, how quickly you're filling it, because we want to understand, is your bleeding abnormal? Does that need to be investigated? Have you developed anemia from that blood loss? Or are you a woman who's now, say, 58 and has been in menopause for 3 years and now having bleeding? That is also not normal. So we really want to understand what's happening with your bleeding. Are you having any hot flushes? So we've talked about what this is: night sweats during the night, hot flushes or hot flashes during the day. If it's mild, moderate, or severe, a moderate hot flush is when you experience the flush and you actually have sweat pearls on your face or on your body. And a severe hot flush is where you experience the flush, you sweat, and you also have to stop what you're doing. So we want to understand how bad it is for you, how much of an impact it has on your day-to-day function. We want to address the genitourinary syndrome of menopause, which is what question 3 and 4 address in terms of vaginal symptoms, bladder symptoms, and sexual function. We want to address your sleep as well as your mood. So what time you fall asleep, how long it takes you to fall asleep, how many awakenings you're having at nighttime, maybe you have sleep apnea, and finally your mood. And with respect to your mood, it's important for us as doctors to understand, do you have a history of depression? Did you have postpartum anxiety? Did you have postpartum depression? Have you had PTSD from a previous traumatic life episode or any adverse childhood events? Because these actually do increase your risk of mood changes during perimenopause and menopause. Once we've addressed the questions, the next thing is we want to look at what is your breast cancer risk. And why that's important to know is that the various forms of hormone therapy that are approved by Health Canada have an implication in terms of breast cancer risk. And we have some hormone therapies which actually may be neutral or antagonistic to breast tissue. So it's important for patients who are considering hormone therapy to do a breast cancer screening assessment and to have a mammogram. And I'll tell you and explain to you why. So breast density is the biggest part of this conversation. When a woman goes for a mammogram, of course, we get a result that's either normal or abnormal. But what we also now get in the majority of centers across the country is a breast density. Whether you have large or small breasts or asymmetrical breasts, you will never be able to determine your breast density just by touching or feeling or looking at the breasts. You actually have to have a mammogram to determine your breast density. So what this means by breast density is if you go from the left to the right, it's quantified as A, B, C, or D. So when you are an A breast density, it's pretty black on the mammogram. And as you move to the right, B, C, and D, the breast tissue and breast density becomes more white because that tissue is more fibrous and it's more dense. And that's important to know because unfortunately, breast cancer, if it's found on a mammogram, is also white. So if you have a category C or category D breast density, you have much more fibrous, dense tissue, and that means that we have a higher chance of missing a cancer in your breasts. It also means that you have a higher risk of developing breast cancer just by having denser breasts. So it's important for a woman to have a mammogram as part of her midlife assessment so that we can determine A, do you have dense breasts? And B, how often you should be getting screened? And C, if you do have dense breasts, you must also consider having an ultrasound for further assessment of any breast cancer diagnosis. And as you can see here in this slide, from left to right, the denser the breasts, you can also see that that does increase your relative risk of breast cancer. So this is why it's important for us as women, again, to not only have a mammogram done in preparation for a midlife health assessment and hormone therapy, but also to ensure that we are up to date with our breast screening, as well as ensuring that we understand what our individual risk of breast cancer is. And when we think about hormone therapy, I understand that from the Women's Health Initiative that there's a fear around hormone therapy causing breast cancer, but I really want to put this into perspective for you. So what this is really is a demonstration of relative risk of breast cancer based on various risk factors. So at the top left, the BRCA gene mutation is the highest risk for any woman to develop breast cancer. The second highest is actually an increased breast density. And if you can see here, that risk is even higher than having a mother or a sibling who's had breast cancer. So your breast density increases your risk of breast cancer even more so than a family history of breast cancer. And if you look at the bottom in terms of that pink area, being on hormone therapy actually has quite a low risk for breast cancer. It's not negligible, but it is a small risk. And what we really want to highlight here is that women who have a BMI over 35 or who drink more than 3 units of alcohol per day actually have the same level of risk as a woman on hormone therapy. So it is a small risk, but it's much less in terms of risk compared to family history or even more so breast density. So in individual provinces across the country, there is various breast screening guidelines. In Alberta particularly, women can self-refer for a mammogram at the age of 45, and that means that even if you don't have a family doctor, you can access a mammography on your own by calling a radiology clinic. And my understanding is that in Ontario, you can actually start self-referring at the age of 40. You may need to look at your own individual province to understand what the individual breast screening guidelines are. But I really want to highlight for you that you may be able to access this even without a healthcare provider. And as I mentioned as well, dense breasts are very common. 56% of women in their 40s have dense breasts. The incidence of breast cancer increases after the age of 40. 16% of breast cancers are actually found in women in their 40s. And the earlier we diagnose, the less likely that there is going to be a woman who dies from her breast cancer, who may have otherwise missed a mammogram. And just to highlight this one other slide here, there are online tools that women can actually do their own breast cancer risk assessment. This is one in particular called the Tyrer-Cuzick Risk Assessment Calculator, which you can find online free of charge, where you can enter in some specific demographic information, your breast density and family history, and it will actually help you understand what your individual risk of breast cancer is. So once we've done the breast cancer risk assessment, the next thing is we want to look at your bone health. What is your risk of developing osteoporosis and your fracture risk? 2 million women in Canada actually have osteoporosis, and fracture risk increases with advancing age. As we lose our independence, we lose skeletal muscle and we lose muscle mass. There's a higher risk of falling, and this is really what we're trying to prevent. Having a fracture has a significant impact on quality of life, increases risk of morbidity, your autonomy and your independence, as well as increasing your risk of mortality. So we as healthcare providers need to also assess what your bone health risk is as we are talking about hormone therapy and your individual menopause journey. The musculoskeletal syndrome of menopause, as I mentioned, did have a paper that was published in 2024, and 70% of women will experience this. So it's important that you recognize these symptoms in terms of muscle loss, in terms of arthritis, in terms of frozen shoulder, in terms of arthritis and just aches and pains that were otherwise not explainable to you before. So we do have osteoporosis guidelines in Canada, and I really want to highlight here that at the age of 50, it's important that every patient considers whether or not she should have a bone mineral density done. Now, in general, if you don't have any risk factors, we don't really start screening until 65 or 70, but these are a list of some of the common risk factors. And if you feel that you have at least 2 of these symptoms or risk factors, you may want to discuss with your healthcare provider about having an early bone density. And again, from the Canadian Osteoporosis Guidelines, this highlights for individual women based on your age and your risk factors if you should or should not have a bone density. And once you've had a bone density test done, the next step is actually trying to calculate your risk of fracture, because that's the most important part. Not only is it knowing what your bone density is, it's understanding that in the context of your age and other risk factors. And we have a couple of tools to help you do that. One is called the FRAX tool, and one is called the CAROC tool, which I will show and explain to you now on the next slide. So on the left is the CAROC system. The CAROC system is primarily what I see used in Alberta, and the way they calculate fracture risk for a woman is just based on the result of the bone density in terms of T-score and the woman's age. And then you're qualified as being low, moderate, or high risk. And based on where you fall into that risk category, your doctor may or may not talk to you about medications to support your bone density and bone health. On the right-hand side is the FRAX tool. And as I mentioned earlier, this is available free of charge online, where not only are we looking at your age and the T-score on your bone density test, but we're also looking at other risk factors that can help us determine your risk of developing a fracture in the next 10 years. And again, what we're looking for is whether you're low, moderate, or high risk, and that will help us to determine whether you are a patient who should consider medications to protect their bones. And so what we look for in particular is if you are a patient that is in that low, moderate, or high risk, low meaning in that blue category, yellow meaning in that moderate risk category, and then red being in that high risk category. In general, we recommend treatment if your fracture risk is more than 20% or more than 3% risk for hip fracture. Now, I know this is beyond the scope of today's presentation, but I really just wanted to highlight to you that when we're talking about your menopause, your risk of bone density increases over that menopause transition, and there may be a role for considering a bone density test earlier on, and ensuring that you have the knowledge and the tools to have that conversation with your healthcare provider. And finally, not only is bone density, something to consider on a isolated basis, but it's important to also think about what we can do in terms of lifestyle. And for women who are above the age of 50, we're recommending at least 1,200 milligrams of elemental calcium to support your bone health beyond menopause, as well as 400 to 600 international units of vitamin D daily. We also want to highlight that women want to focus on regular balance and functional training, as well as resistance training to maintain their skeletal muscle and skeletal bone mass, as well as a muscle mass as well. And finally, after talking about breast health and bone health, we want to understand what is your risk of heart disease, because actually heart disease is the #1 cause of mortality for women in Canada. Every 16 minutes, a woman will experience a heart attack in Canada. And although we worry about breast cancer, it's actually heart disease that is the #1 killer of women. And we need to understand this so that we can advocate for our health and our heart health as well. And this is sort of what I just highlighted here. And interestingly enough, the symptoms of a heart attack present very differently for women, which is why 80% of women are not aware of their individual risk factors and what a heart attack may actually present as for that individual. So when we look at risk factors for women in particular, we have them categorized into 3 different areas. And if we break this down, on the left-hand side, many of these may be familiar to you, but on the second and third category, these are risk factors for heart disease that may not be well understood. But as a woman, it's important that you think about these things. And as a healthcare provider, it's important for us to ask these things because it's important for us to then understand what that risk might be as we are considering hormone therapy for you to treat your menopausal symptoms. So on the left, age, high blood pressure, high cholesterol, diabetes, obesity, unhealthy diet, increased BMI, and tobacco use are known risk factors for heart disease. But if a woman has gone into early or premature menopause, under 45 for early and under 40 for premature, for this category of women, if we don't offer hormone therapy until the average age of menopause, which is 51, they're at high risk of developing heart disease. And one of our lived experience individuals will share her story about going into menopause early. If you've had diabetes in pregnancy, preeclampsia, preterm delivery, or if you have a history of polycystic ovarian syndrome, these are also risk factors for heart disease later on in life, which we don't recognize routinely. And there are many unrecognized factors as well. A history of depression, anxiety, socioeconomic status, your cultural status, poverty, and poor health literacy actually also increase heart disease risk. So once we understand what our individual numbers are, we can then look at, okay, so if I do have high cholesterol or I have diabetes or I have high blood pressure, what does that mean for me in terms of my risk of developing a stroke or heart attack in the next 10 years? In Canada, we as healthcare providers do have a scoring system called the Framingham Risk Score, and it takes into account some of the risk factors, not all of them. So it's not a perfect scoring system, but it does highlight maybe some of the things you want to be considering. And as a woman, you can actually access these scoring tables online on your own at the listed websites down below. And again, what we do is once you've calculated your risk score, we're looking to understand, do you have a low risk, moderate risk, or high risk of developing a stroke or heart attack in the next 10 years? And that will, again, help us to determine whether you may be a patient who has implications for what hormone therapy regimen you want to consider, but also whether you want to consider taking medication to help control your cholesterol, because really at the end of the day, that's what we use this Framingham Risk Score for, is to help determine whether a patient should use a statin medication to help bring her cholesterol down. So these are the Canadian Cardiovascular Society guidelines, again, highlighting whether or not you may want to consider a statin or a cholesterol lowering medication based on your individual numbers and your risk assessment, keeping in mind that the Framingham Risk Score does not take into account all the risk factors, but it's important for us to consider it as some sort of assessment tool. I also order and consider ordering a lipoprotein A level, which is a genetic risk factor, which is a blood test that you can order once in your lifetime. I don't know if it's covered by most provinces, but the lipoprotein A, if elevated over 100, can help us to determine whether you may have a genetic predisposition to heart disease and may help you determine whether you want to consider a cholesterol lowering medication. Of course, family history is also important. And as South Asian community, we know that heart disease risk is higher in our group compared to other nationalities and ethnic groups. And so in summary, I've highlighted to you how to do a women's health assessment, what you need to bring in terms of presenting to your healthcare provider, and what we as healthcare providers need to do in terms of a risk assessment, in terms of your breast cancer risk, your heart disease risk, as well as your risk for developing osteoporosis. So in the next webinar, we're going to talk more about treatment options, but really what I want to highlight for you here is that I see menopause as the start of the next fabulous phase of a life for a woman. Now is our time to tune into our bodies and to embrace this new chapter. So I hope that over the last hour that we've been together in this webinar, I've been able to highlight to you why it's important for us as women to be empowered during our menopause journey and our menopause experience, and that we have the knowledge now to understand what symptoms to look for and what specific risk factors we may have. And that's going to help you, as well as your healthcare provider, come up with an individualized, comprehensive, and personalized plan to address not only your symptoms, but overall not only to address your symptoms, but your overall healthy aging. And with that, I thank you very much for your time. Yali.
Thank you, Dr. Premji, for sharing your expertise on menopause. Your insights are invaluable in helping us better understand this important topic, and we truly appreciate your time and knowledge. I would like to now welcome Ruksana Samji, who will share her personal journey with menopause. Through her lived experience, Ruksana will provide a first-hand perspective on the impact of menopause on her life and insight into the lessons she's learned along the way.
Yali everyone. My name is Ruksana, and I am here to share my experience. So initially, my symptoms started around my 40th birthday, but at the time, I didn't know the symptoms were perimenopause. I didn't know what I was experiencing. It started off with very, very bad migraines, headaches. Simple things like Tylenol, Advil wouldn't really do anything. I went in with my symptoms. I was sent for an MRI. They couldn't find anything. I was advised that perhaps it's just weather changes, climate changes. The symptoms started to progress. I stopped getting my monthly cycle. That went on for 6 months, and it was on and off again. I was told perhaps I'm too young to be going through perimenopause. It was too early for that to be happening. Perhaps it's stress. It was also during COVID, so stress seemed like a realistic possibility. Shortly after that, other symptoms began. I was tired all the time, very low energy, weight gain, hot flashes during the day, night sweats, and it just didn't seem that anything could alleviate those symptoms. I then read an article that was posted about women who around the age of 40 can start to have symptoms, or even earlier, and that a lot of those symptoms that were listed in the article posted by Dr. Premji had to do with the symptoms that I was experiencing. And it was at that point that I went in and I was advised by Dr. Premji that I should have a blood test done. I went back to my healthcare professional and asked for a blood test, and once I received the results of those blood tests, it was confirmed that those were the symptoms. But I think because the symptoms are so isolated, headaches and then night sweats and low energy and weight gain, you're always looking for sort of the most practical answer. Okay, if I'm gaining weight, I need to exercise and eat better. Okay, if I have headaches, I need to drink more water, I need to get more rest. If I'm tired all the time, I'm probably not eating the right foods. And having two young children, it was really hard to keep up with them when I was going through all of this and not sleeping and not feeling good and not feeling confident about myself anymore. And after it was all confirmed, I saw Dr. Premji and I started hormone therapy, which was estrogen and progesterone, and it immediately changed my life. All of my symptoms were gone after the treatment started. I don't experience any of those symptoms anymore. Literally every single one was gone once I started that. And I think my advice to others, to other women who are experiencing things, number one, don't ignore your symptoms. Don't dismiss your symptoms. Don't brush it off. Don't feel like you have to push through or power through. If you're not getting the help you need, just really advocate for yourself, advocate for your needs. If you feel like you know possibly what's wrong, just speak up. Don't be afraid to speak up. I think it's something that we don't talk about very much. We don't talk to other women about this, and I think we should. Because now I'm on this therapy and I have more energy and I'm getting rest and I'm sleeping well and I'm back to living a healthier lifestyle. I am able to have time to exercise and the energy to exercise and participate in activities with my kids. And I have more motivation to eat better and eat right because it's actually making a difference now. So it's not just been a change for my symptoms, it's been a change for my lifestyle and essentially getting my life back. And I just want to add one more thing just to make everyone aware that I am actually in early menopause. I started full menopause before the age of 45. The dose of estrogen that I'm on is a very high dose. And the reason it has to be a high dose is because one of the risks that women experience if they enter into menopause early is heart health. And I'm sure Dr. Premji will speak more about this, but that is something that women in early menopause have to think about and educate themselves on the health factors that come along with experiencing menopause before the age of 45. So I'm just really happy to be a part of this conversation and be invited to this. And I'm just very grateful and thankful for the medical attention that I received once I was diagnosed.
Thank you, Ruksana, for sharing your personal journey with us. Your experience helps foster a deeper understanding of menopause, and we truly appreciate you lending your voice to this important conversation. This brings us to the end of today's session. We would like to leave you all with some helpful resources. For the latest updates and information, visit iicanada.org, where you'll find a variety of resources, webinars on health-related topics. For personalized support, you can contact the Access line by scanning the QR code or dialing the phone number on this slide. Finally, I would like to thank Dr. Shafeena Premji and Ruksana Samji again for sharing their knowledge and experiences with us today. We would also like to thank our audience. We hope you enjoyed today's webinar and learned a few things to help you understand menopause. Your feedback is very valuable to us and helps us develop and share further programming. We ask you to please take a few minutes out of your day to complete the evaluation survey found in the description of this video. Until next time, and ya Alim Madat.